Continuing on with our next speaker, I would like to welcome up Natalie Lilly, who is one of our clinical geneticists here at Dell Children's Hospital. She is a genetics counselor in our neurosciences division. She received her education at Boston University and Scripps College. She completed fellowship in leadership. She completed a fellowship in leadership, neurodevelopmental, and related disabilities at Boston Children's Hospital. And today she's going to be bringing us information on the genetics of NF1.
Thank you so much. Hi, everyone. My name's Natalie. I'm a genetics counselor, and I'll be speaking today about the genetics of NF1. So first of all, I just wanted to say thank you for submitting questions ahead of time. I've really geared my talk today towards the questions that Carla collected over the last few months. So this will kind of be our outline for today's agenda. Today we'll be going over an overview of genetics and how NF1 ties into that. We'll again briefly touch on the clinical features of NF1 that Dr. Moodley talked about earlier. We'll talk about the inheritance, the prevalence, how this genetic change is either brand new or inherited, passed down through families, and any type of genotype or phenotype correlations. By genotype, phenotype, we mean sometimes there can be a certain genetic change where we would expect to see certain clinical features as a result of that. So we can talk about that in a little bit more detail. All right, so you may have heard about this before, but to orient us within this talk, I wanted to go over an overview of what I mean by genetics. This is a handout we give our families in our neurogenetics clinic. So we have billions and billions of cells in our body. Within our cells, we have 46 chromosomes. They're in pairs. We have 23 pairs, and we have, girls typically have two X's, boys have X and a Y. These are like packages of our genetic information. We can think of our genetic information like an instruction manual for our body. It tells our body how to move, grow, develop the way that it's supposed to. Within this chromosome, if we unravel all of our DNA, we get this classic double helix feature. Segments of this are called genes, and the gene that is associated with NF1 is called NF1. It creates and genes code for proteins that execute different functions in our body. So as we talked about earlier, the NF1 gene is on chromosome 17. And NF1 regulates cell growth and division. So it acts as a tumor suppressor gene, which is why when the instruction for creating this protein is altered, that tumor suppression isn't working as well as it typically should. And so NF1 in the genetic world is a very common condition. It's estimated to be 1 out of every 3,000 people have this condition. 50% of the time, having a change in this gene is passed down. The other 50% of the time, it's brand new. And a random change that happened either early in development or in that one particular egg or sperm cell. This is just an overview of different changes in the cell or in the gene can cause different expression of symptoms. So most of the time, NF1 can present very mildly, but other times there can be moderate or more severe presentations of NF1. Importantly, NF1 can be expressed very differently, even throughout families. So one particular change, just because it expresses, in one child may not look the same in their sibling or their kids in the future. So one of the questions was, are there secondary effects of NF1 that can appear over time? This was a really great question. And I'm not going to spend too much time on this since Dr. Moodley went over it earlier, but I did want to include it for reference in the future and on your handouts. I wanted to include this table because it goes through the different features that can be seen, as well as the frequency with which they're seen and the potential age of onset. So there are some clinical features that happen more in childhood, and some can go on to occur throughout life, such as neurofibromas. Those can increase over time. So some features can kind of continue throughout the lifetime. In terms of diagnostic criteria for NF1, Dr. Moodley, again, went over most of these, but I wanted to focus primarily on the genetic component that is contributing to the diagnostic criteria. And we'll talk about this a little bit further in the talk as well. So a positive NF1 variant that can be detected on genetic testing does count towards diagnosing a clinical criteria. There is a we'll talk a little bit more about other types of genetic testing results that can come up, but there does need to be a positive in order for it to be contributory towards a clinical diagnosis. If it's an uncertain variant that pops up on genetic testing, that does not count towards a clinical diagnosis. So does NF1 occur in all generations? Does it skip generations? This was another really great question. So NF1, regardless of whether it was passed down in the family or whether it was a brand new genetic change, all of that genetic change follows an autosomal dominant inheritance pattern. So the NF1 variant is present on one copy of the NF1 gene on one chromosome. So you have two copies of each gene. And just one variant is enough to cause symptoms of this condition or cause a diagnosis. And so with that, there's a 50% chance with each pregnancy of passing that gene down to a child. This condition does affect boys and girls equally. So having, a son or a daughter doesn't necessarily, it's not sex limited, essentially. It's the same chance of inheriting. If you have a genetic component in your family and your child does not have that, then they can't pass that down to a future pregnancy. And we can talk about that a little bit more down the line too. How difficult is it to detect NF1 through genetic testing? Good question. So are people familiar with genetic testing in here? I wanted to give a little overview of what I mean when we're talking about genetic testing. So these days, genetic testing can be done through a saliva cheek swab, and we typically test for an NF1 panel. So that looks at NF1, NF2, and the spread1 gene. And when we do this, we can get three possible results. So when we get a positive result, it means we found a change in the NF1 gene that we know is associated with this condition. We've seen it before. There's enough evidence that can be applied to this specific genetic change that we know is associated with the condition. We could get a negative, which means, okay, we didn't find a change in the NF1 gene. That being said, if you don't have a genetic change, you can still have a clinical diagnosis of NF1. So it's not a requirement to a diagnosis. It just can contribute. Or thirdly, we can get a variant of uncertain significance. And what a variant of uncertain significance means is that there was a change that was detected in the NF1 gene, but we either haven't seen it before or there's conflicting evidence applied to it. And so we're not really sure what it means. It's something that we would keep an eye on and see if it is seen in more individuals down the line, and we're able to apply any other criteria towards it to either reclassify it as positive or negative. Right now, a variant of uncertain significance does not, again, contribute to a diagnosis or count as a criteria. For for NF1, we're able to find a genetic change when there's one to be found about 90 to 95% of the time. So this is pretty good sensitivity for this test. And we just talked about this with a little bit in a little bit more detail. Again, you can have NF1 without having an identified variant. There also, I'm not going to spend too much time on this, but there is the possibility of mosaic NF1, which means that you can have a change in NF1 in some cells of your body, and your other cells wouldn't have it. So depending on which tissues contain this change, we're able to detect it sometimes. Sometimes it's not present in blood, but it's just present in your skin cells. So depending what tissues we sample, we may be able to find a variant or not. Okay, does NF1 become more severe as it is passed on through each generation in the family? This is a really good question. So in terms of NF1 inheritance and expression, so penetrance for NF1 is close to 100%. What I mean, or what we mean when we say penetrance is if you have a change, a genetic change, there will always be some type of symptom. So some genetic conditions have reduced penetrance, which means that you have the possibility of never showing symptoms of a condition. For NF1, penetrance is close to 100%, which means that it is extremely likely if you have a genetic change that you will have some type of symptom, whether that's cafe au lait macules or freckling or any other type of clinical feature associated with NF1. Features may be more or less severe than a parent with NF1 or somebody else in your family with NF1. So variable expressivity or variable expression means that even though it is likely to have symptoms of some kind, being able to predict which symptoms that will show up we're not able to clearly identify that quite yet. And so we can't really say exactly what the prognosis or what to expect in the future. We would just have to go off of that chart that I showed earlier in the talk that shows the frequency of certain clinical features. So what can the type of NF1 variant tell us? So again, for NF1 in particular, there are relatively few correlations between the type of genetic change and expectation. So also, to back up, when I talk about type of genetic change, I wanted to give an example of what I was talking about. So when we do genetic testing and look at these 3 specific genes that are associated with NF1, what the lab is doing is essentially proofreading your genes. And we're looking for any type of change. So if this is what the lab would expect to see, we're looking to see even if there's something as small as a single letter change in the gene, or an inserted word, or a deleted word, or a sentence that ends prematurely. This all would have an impact on how the ultimate protein that is produced from this instruction functions. And so right now, depending on, if you have a switched letter or a deleted word within that instruction manual, we don't have a great prediction. I think that will change in the future. There is a lot of research going on about that genotype-phenotype correlation, but we're not there quite yet. There are some known single letter changes that can lead to a higher or lower than expected chance of certain features. And that's something that you can talk to a genetic counselor or me to understand if there's been a correlation for that specific change. We are essentially limited to what has been published in the literature before. Has that change been seen? And what type of features have been reported out? So for those specific nuanced questions, that is part of my job to look into that more specifically for your family. Importantly, the management recommendations for NF1 are standard and comprehensive, no matter what type of genetic change you have, or even if you don't have a genetic change for clinical management, it's the same for all. Okay, we talked about that. Okay, how does NF1 affect your child's life, and does it cause malignant cancer? So I know Dr. Moodley and our previous speakers touched on this briefly. Typically, NF1 causes benign tumor growth. That being said, cancer can be seen with NF1. There is malignant peripheral nerve sheath tumors, which are the most common type of malignant neoplasms in NF1. These typically arise from plexiform neurofibromas. About 20% of people with NF1 develop plexiform neurofibromas, and then 10% of that 20% go on to develop MP-NST. Signs and symptoms are any type of persistent pain or rapid growth of plexiform neurofibromas, and that's something that Dr. Moodley would monitor closely. There is, when we were talking about that genotype-phenotype correlation, we do know that the deletion of the whole NF1 gene, so not necessarily a single letter change, but a whole gene deletion, is at a slightly greater risk for MP and ST. So that is one thing that we would look out for if we saw that on a genetic testing result. There is a slightly increased risk for breast cancer for women. And so for that, the recommendation is to begin mammogram screening a little bit earlier at 30 years of age instead of later. I've also listed out a few other cancers that have been reported in the literature, although it should be noted that additional screening for these rarer types of malignancies is not recommended for people who don't have any symptoms. So it's just something that we would look out for, but we wouldn't do any asymptomatic screening. And importantly, as you all know, individuals with NF1 live very full and normal lives. When and how should we discuss an NF1 diagnosis with our children? This was a really, really great question. So I looked into the literature, and I wanted to come at this from a little bit of a genetic lens, and I pulled the main points from this article that's called Parent Perspectives on Disclosing a Pediatric Neurofibromatosis Type 1 Diagnosis. The prevailing thought was to be open and honest. You know your child best, and in considering the family dynamics, child's age, and child's personality, this is just an important conversation to keep open. There's no one best approach to disclosure, but one resource that I did want to bring up, because this article did talk about a lack of NF1 specific resources, is our certified child life specialist. And you may have seen Ruby's with your kids right now, but a child life specialist is a medical professional with training in child development, and they have specific expertise in helping children understand and cope with medical diagnoses. And so Ruby is specifically works with children with NF1. And so I spent some time talking with the child life team, and what we talked about was that children between the ages 3 to 7 tend to have vivid imaginations. And so what works best between those years is to provide reassurance and propose a solution if there's any stress or anxiety. And by propose a solution, an example of that is, if you're feeling worried, we can go see the Dr. Moodley and talk about this. And if you have a comprehensive care team who's here to support you. And so provide that reassurance. In terms of discussing the genetic side of this condition, typically around age 12 or 13 is a reasonable time to bring that up. Bless you. And to kind of introduce that topic. This is an open conversation. Genetics are intensely personal, and just having that connection, with your child about what this means, what this looks like, will be really important as they grow. In terms of resources, these are links, which I know is not helpful necessarily, but these are the types of sources I pulled the information from this talk from. The NF Parent Guidebook, extremely useful. And then we have our wonderful foundations, both locally and nationally, supporting us as well. And then citations as well. And then that is all. I know we have a little extra time. I won't be able to stay later for the Q&A, so I was wondering if it's okay, could I take questions now?
We can make that happen.
I have multiple questions.
Okay.
The first one is if I have NF1, does that mean that the chances of my children having NF1 are still 50%, or does it increase?
That's a really, really good question. Have you done genetic testing before?
I don't think so.
Don't think so. Okay. So that's a really good question. So with a genetic component, we can say with accuracy that there's a 50% chance of passing down that particular variant to a child. However, without having that specific variant, we talked about earlier how you can have a clinical diagnosis of NF1 without necessarily having that genetic component identified. And so there is a higher likelihood, but I can't give an exact percentage if we don't have that particular variant to go off of. Does that
Yes.
make sense?
So then the follow-up question to that is, if in fact that is the case, does that not mathematically mean that NF1 will continue to increase in prevalence until at some point in time it's in everybody?
So
Over thousands of years I'm talking about?
I want to make sure I'm following the question. You're saying that passing it down everybody will just continue to pass it down to kids? Can you
Right, because
rephrase? I'm
be-
sorry.
because first it appears just randomly in the
I
population,
see what you're saying.
and because for people who already have it, it appears at a greater percentage than what it does occur randomly. That suggests to me, mathematically speaking, that it will increase in the population over the course of time.
I think there are different studies have cited different prevalence, and so there are some studies that even say 1 out of every 1,000 people have NF1. I think it's difficult for us to extrapolate that. What I can tell you is that this gene, the NF1 gene, is one of the genes that we know about in the body that's most susceptible to creating these random changes. So a 50% de novo rate, or where it's not passed down in the family, you're the first one to have this change, 50% is relatively high. And so, there's a possibility that could happen, and this incidence would increase in the future. I can't speak to what will I think. Do I think that's going to happen? I'm not sure, but I could see the incidence increasing in the future.
I'll speak just a little, to that. Your numbers, I see where you're coming from, and so that seems to make sense that it would become more common rather than less common. I think some of it has to go into how big and fast is the population actually growing, and there's a lot of dynamics to it. That,
Yeah, I mean, it's a math question.
yes, there would be, then your maths and your statistics make sense. I think it kind of depends on if the population at large is actually growing or not.
So if I may, if a child has NF1, is there any advantage to knowing whether or not it was passed down or whether or not it was random?
It's a really good question. Genetic testing is always optional. It's always a part of the toolkit. It's never mandatory. We always tell our families what would getting a genetic diagnosis or understanding a genetic etiology mean for you? How would you integrate that information into caring for your child? How old is your child? Are they thinking about, having kids of their own in the future, and they want to know what that would mean or what that would look like in terms of family planning? So we always have an in-depth discussion of, what would this genetic change mean for you, and how would you integrate that into your family conversations? So I think it depends. I think it's really great information to have, and also having that information, what are you going to do with it, and how would that affect your family dynamic? So I think it depends, and that's why you see it.
So I understand that it's the same question about whether or not you should run a test to see if a 95-year-old has cancer, because if a 95-year-old has cancer, are you going to treat the cancer? Why would you at 95, since their life expectancy is so short to begin with? I understand the concept, but is there any specific reason why it is an advantage?
I think, well, there's lots of pros to it, but I think knowing your specific genetic change does make you more eligible for different clinical trials and research in the future. So I will say, I do think it is important to know that.
All right, we have a question just
Yeah.
behind you. I want to be sure we get everyone.
Yes,
an
our
opportunity.
daughter early on was diagnosed, but was negative on the
Genetic testing.
original test. We do not have it in our generation or other children, and going back a few generations from everyone that we've searched. No sign of it that we know of. So could you talk a little bit more about this kind of spontaneous change that happens? And is there any research into why it happens?
Yeah.
And is there any advantage to my wife and I getting tested or other children to try to determine the link?
So that's a really good question. So for negative results, it's tricky because NF1 is still something that we're learning more about. It's possible that there's another gene that we just don't know of that causes the same clinical presentation. And so it's also possible that she has a form of mosaicism. Again, some of her cells have this change and some don't. And so it's possible. Did she do a cheek swab? Or did she?
This was before they had, I
Okay, it's
think,
blood draw or okay.
blood.
Blood draw. Yeah. Yeah. And so I think depending on it just might not be present in her blood. It might be present in just on her skin. And so we wouldn't necessarily it is possible to do a fibroblast cell sample to see if her specific cafe au lait spots contain a change. But I think that there are a couple different reasons it could be negative. The other thing it could be negative, we're learning more about our genetics and different changes within NF1. Over 1,000 changes within the NF1 gene have been, called out and determined to be pathogenic or positive. And so we are learning more about those changes all the time. So it's possible that she also has a change that we didn't know about when she was first tested. So you could, consider doing a reanalysis if you wanted in the future of a negative result. In terms to your follow-up question about is it worth being tested yourself, if you have no symptoms or no features of this condition, we wouldn't necessarily recommend it. Likely it would come back negative as well. Yeah.
Thank you.
One question here up front, and then we will close out the question session.
It's regarding to his question,
Yes.
like in the future, the population of NF1 will be more.
Yes.
So is it possible if we can incorporate that genetic testing during pregnancy as standard testing?
That's really, really good question. So during pregnancy, if there's a known genetic variant in your family, then you can test specifically for that variant during pregnancy. In terms of doing blanket NF1 testing, that's not typically included right now in a prenatal workup. There's other types of genetic testing that is kind of in the prenatal realm. With NF1, I think that's certainly something that can be incorporated more in the future. And that's a really good question. I want to talk to my colleagues about that to see what that would necessarily look like. But in terms of targeted testing, that is currently a possibility that we have access to.
Okay. I'll take a moment to just comment on that because it was some of the questions I had
Great.
for you, which are really more comments than questions. I did attend a conference earlier October, just last month, that was specific to not prenatal testing, like I'm already pregnant and I want to know if this pregnancy is impacted, but more family planning and sperm testing and egg testing. So very, very early in the family planning stage. And if they have diagnosed or found the actual mutation in the family, then they can do some testing on either the egg or the sperm, depending on if it's coming from the mom or the dad cell line, and determine which ones are impacted, and then do something similar to in vitro fertilization with unimpacted or normal sperm, normal eggs. This is extremely early stage, not new age, but new medicine, relatively new. So it's not very common. It's definitely not well covered by insurance. Most of the time it's not covered at all. So it's very expensive. But to your question, future, where are we going to be 5, 10, 15 years from now when our little ones running around are having their family planning? I think that is something that will be more common, more easily done, and more well understood as we start to understand the whole genome of this disorder and the processes involved. So I think there's hope for the future. I think it's very difficult to access some of those resources today. And it takes months to do some of the testing. It might take 6 months just to find the gene change in your specific cells. So it's a very long, drawn-out process, but possible.
Just to comment on that also, yes, egg and sperm testing takes a little longer for us. For testing in clinic, it takes about 4 to 6 weeks to do a cheek swab. We don't even need to do a blood draw anymore. So that is a relatively quick turnaround time.
All right. Thank you so much.
Thank you.
Very informative lecture. And we will continue on. Dr. Moodley will introduce our next series of speakers.